Hello, everybody. Welcome to International Thermogram Rounds, year 12. It's a pleasure to have you all here today again for another meeting. We're going to have a case presented by the Unicamp group, Dr. Gustavo Fraga, Professor of Surgery, Director of Visual Trauma Surgery at the University of Campinas, Brazil. Dr. Mayra Negrao, General Surgery Resident, PGY 4. And Dr. Heitor Ramos, Radiologist Resident, PGY number 3. They're going to talk about a case of motorcycle crash. It's a pleasure to have you all here. Please let us know if you want to interact. So they're going to present the case. They're going to have some questions during the case and some live interaction. Thank you very much, Dr. Fraga, Dr. Negrao.
Okay, so I'm going to talk about a motorcycle crash, a continuous problem. I'm Mayra Negrao, a resident of 4 years, and the professor Gustavo Fraga, and my friend Heitor Ramos, a radiologist resident of 30 years. Here in Campinas, we have in 2021, 161 fatal victims of accidents with car or motorcycles. The motorcyclists are the main fatal victims. Last year, we have 69 fatal victims with motorcycles, how we can see in this graphic. So this month we have a campaign, yellow campaign, that says that together we save lives. The yellow is for attention in the traffic. So don't drink before driving. We need to respect the speed limits and respect the traffic laws. We have some t-shirts about the campaign and says no traffic death is acceptable. So we are going to talk about motorcycle crash with a pole, a pre-hospital. The man was 21 years old. He was stable, just having hematuria. The accident was at 7 a.m. On day 4. The initial care here, we have a pervent airway, stable cervical spine, and B, universal audible vesicular murmur, preserved expansibility, saturing 99%. C, heart rate 95, blood pressure 140/60, capillary refill time more than 3 seconds, and the patient referred painful abdomen but without peritonitis. EFAST was positive and hepatorenal window, stable pelvis. D, Glasgow 14, he was a little bit confused, but esophageal reactive pupils. And E, some ecchymosis and scoriation in a thoracic abdominal transition in the right side. This was the first exam, so we can see a little bit of acidosis with a base excess of -4.7. Lactato was a little bit high, 3.8, and the hemoglobin was 9.5. So we are going to ask you, what would you do? Like, he was stable, and so I think we need to discuss if you're going to ask some more exams or do blood or do an TC. This is the first question of my presentation.
Thank you, Doctor. Dr. Kasim, your comments? Good morning. So this is a 22-year-old man, as I understood this, that he crashed into a pole and sustained accident, motorcycle versus a stationary pole. And of course, the motorcycle and the person who's on it will sustain majority of the injury. And he looks to be quite stable, hemodynamically speaking. His blood pressure looks okay, his pulse rate looks okay, and he doesn't seem to have any airway problem. But he does have hematuria, and EFAS is positive. So the first thing you would do in a case like this would be to secure the airway and follow the ATLS protocol. And investigation-wise, you have drawn the blood, and there is one finding in the blood draw which is grossly abnormal for a 22-year-old man. His hemoglobin hematocrit is markedly down unless he has pre-existing anemia. I don't think that is possible. So you have to summarize from the lab at least that he's lost blood. So he does have hematuria and he's got EFAS that is positive. So you would do a chest x-ray, you would do the usual abdominal x-ray, and then you would at least think about getting some type of contrast studies of the genitourinary system to see why he has hematuria. You can do ultrasound of the kidneys, and you can look at the bladder, and if time permits, you might even want to do a cystogram. But before that, I think because he's got blood in the peritoneal cavity, I think you would probably, under the circumstances, because he's stable, you could safely send him for a CT of the thorax and the abdomen and the pelvis. That's what I would do. Thank you.
Thank you, Dr. Kasim. Dr. Antrak, your comments?
Yeah, so I agree with all that. In this case, I would take him to the CT scanner and do at least at the neck, because he presumably fell off the motorcycle, and you don't know how he landed, but many of these patients land on their back, and you could have fractures not only of the kidney but the adjacent ribs and the liver, retrohepatic vena cava, all resulting in the bleeding that he has. So I would take the opportunity while he's stable and while the blood bank is preparing for transfusion if needed, at least the neck, the chest, abdomen, and pelvis, and possibly, if he's going to the CT scan, I would probably include the head as well. Since he's stable and while he's stable, I would do that first.
Thank you, Dr. Antrak. Dr. Vega, Mexico. Dr. Vega, can you hear us? No. Okay. Then Dr. Viñoles, you had a comment. Would you like to make any comment?
Yes, good afternoon. I think that this patient need a TAC, CT scan body stable. Yeah, yes, it's my comment. Only that is.
Okay, thank you very much. Okay, Dr. Negrao and Fraga, we go back to you. Dr. Hoffman, I know that I see you connected, but I'm not sure if you had a chance to hear the case yet.
No, I'm sorry. I came late. My apologies. I had to do an emergency consult and I missed the presentation. I might be able to jump later, but not now.
Okay, thank you. Thank you. So, Dr. Negrao, we will go back to you.
Okay, so we decided to ask for 2 red blood cells concentrate and the tomography. Can you see the exam?
Yes, we can see.
Hello, my name is Heitor. Can you hear me?
Yes, we can hear you, Dr. Ramos.
So tomography was made, and here we can see first in the non-contrast phase that we had perihepatic free fluid, a small amount of perihepatic free fluid, a large amount of retroperitoneal free fluid, and in the perirenal space, we had an hematoma. So we could already suspect there is a kidney injury, and then was performed contrast phases. In the arterial phase, we could already see that we had some lacerations in the liver that could explain why we had the perihepatic free fluid. And we could see already that the upper half of the kidney was shattered. It was affecting the collecting system, and it was the cause of the perirenal hematoma and this large retroperitoneal hemorrhage. In the next phase, in the portal phase, we could see that there was no active bleeding in the kidney laceration. There was no contrast extravasation, but in the upper half of the kidney, we could see the contrast was outside, was free in the perirenal space. So there was active bleeding, and this was a grade 5 kidney injury in the kidney injury scale because of the shattering of the upper half. In the phase that we can see the excretion of the contrast, we don't see extravasation, we only see it active bleeding. The collecting system is affected, but there was no active extravasation from the collecting system, only arterial and vascular bleeding. The main problem here was the injury of the kidney.
So after this tomography, we were in doubt about laparotomy or not, but the patient started to be a little bit unstable with heartbeat 120 and more confused than he was initially. So, okay.
I think you can discuss now about the treatment. If anyone suggests to try a non-operative treatment, in this patient, or if this patient needs to go to OR, because the patient was tachycardic, a little bit hypotensive, without blood transfusion at this moment. But we ordered 2 units of red blood cells to give to the patients. And I think it's important to discuss if is there any possibility for non-operative treatment in this situation.
Thank you, Dr. Fraga. Dr. Antrak, any comment?
Yes. So here in Baghdad, we would take this patient to the operating room because we don't have the option for non-operative treatment. Looking at the CAT scan, there are large portions of the upper part of the kidney, the upper third or quarter of the kidney seems to be functional, well perfused. It's enhanced and it looks like there's an intact artery to that image to that part of the kidney. And also I'm concerned about what looks like a zone 1 hematoma posterior to the pancreas. And they always need to be explored. However, in Dr. Fraga's hands, I think there's a high likelihood that you gave this patient some blood and he became more stable, and he wasn't transiently stable, but stable, no longer tachycardic, and you probably took him to the interventional radiologist to try and stop the bleeding in that kidney with coils or through embolization.
Thank you, Dr. Antrak. Dr. Kasim, your comments, please.
Well, it depends where you are, in which part of the world you are, whether you have experts available for you to deal with this case. If you are in austere situation, non-operative treatment would not be a good idea, because the patient is bleeding and he has lost considerable amount of blood. And non-operative treatment means you're just watching the patient, and you may be watching the patient to die. So that is not a good idea. So you are now left with 2 other choices, which is interventional treatment or surgical treatment. And if you have an interventional radiologist available, you have the facilities available as well, I think that's what I would go first. I would take the patient to the interventional radiologist suite and opacify the injured kidney. I look at the other kidney looks good. And the reason why you are seeing hematuria is because he's bleeding into the collecting system, and it is showing up into the bladder and in the urine. So it can be treated with coil, etc., gel foam coil, etc., to see if we can stop the bleed and thereby at least try to salvage the injured kidney. And while you are there, you should also squirt and opacify the liver to make sure that you are not overlooking anything in there as well. So you will get, you're killing 2 birds in one stone with one stone. And that's what I would do. Now, if you are not in a center where such experts are not available, then of course you will have to take the patient to the operating room for a laparotomy and deal with it in the operating room. Thank you.
Thank you, Dr. Kasim. Dr. Vega, let me try again because I see that he's connected. Dr. Vega, can you hear us? No. Dr. Hoffman, would you like to make any comment?
Yes, sure. I can comment from here. I don't know what happened before. Can I see the venous face again behind the IVC, where it was they have the delay bleeding? So the thing that is kind of concerning in this CT scan, yeah, everything seems to be coming from the kidney. So there are a few things that are very concerning here. One is that the hematoma extends, as Dr. Untrak pointed out, in front of zone 1. And furthermore, it displaces the IVC anteriorly in an area that is kind of difficult to reach. I will be concerned about a lumbar vein injury there contributing to the bleed, although I don't see any extravasation except around the kidney. Normally, we try to manage all these type of injuries non-operatively, but I think that this patient passed that phase because he's bleeding into the collecting system. This is, I would say that this is a grade 4, not 5, because part of the kidney is not complete avulsion, part of the kidney is still well perfused, but it's a significant destruction of the inferior pole of the kidney with extension into the collecting system. So I doubt very much that this patient will be able to be managed non-operatively, even if you manage to do an embolization of the renal artery, which can make the surgery easier. It's very likely that this will fail. So probably go to the OR and be prepared to do, the moment that you touch this kidney is in the bucket. But also be prepared to look for an injury in the IVC. That will be my concern. That's all. Thank you.
Thank you, Dr. Ochman. I see Dr. Byers connected. I'm not sure if Dr. Byers, you had the opportunity to see the case. Dr. Byers?
Yeah, hi. I'm trying to multitask here. I saw the scan and I agree with the angiography, and I agree also that the hematoma behind the pancreas is concerning. I guess if you would get an angiography, you could make sure there's nothing bad going on there. It just might be blood decompressing from the kidney, I guess, is another possibility. But with a disruption in Gerota's, but I think that needs investigation. I think if you were to operate on this patient, given the damage to the kidney, you would really have a high risk of losing the kidney. But if the patient was unstable and stayed unstable, I didn't hear the very beginning. I'm sorry, because I've been on a million different things, but obviously you have to operate, and then you would try to salvage some of the kidney, but if you can't, you may end up taking out the whole kidney. As long as the other kidney is okay, it's a life-saving maneuver. So that's my opinion.
Thank you, Dr. Byers. Okay, Dr. Negrao. Oh, anyone else? Any comment from the audience? No? Okay, Dr. Negrao, we go back to you.
Hello?
Yes, we can hear.
Here?
Yes, we hear.
Okay, so just we classified by grade 5 because it was charted kidney, and because when we discussed with the radiologist, they say that the main artery and the vein was had not laceration, and so but they classified like grade 5 because of was all the kidney was charted. So we decided for laparotomy to explore the zone 1 and to see how was where was the bleeding. And so we identified there was a huge hematoma, so it was hard to find the aorta and the cava, the cava vein. But we find after take off this hematoma. So here was the aorta and the right renal artery and the right renal vein. And in the vein, there was the cava. There was a little bit, small that we suture, repaired, and this is the kidney after we took it off.
So we consider the laparotomy and the nephrectomy was performed, I think was the safe option for this patient in this situation the patient was. So after the laparotomy, how do you want to discuss now about this? The radiologist, interventional radiologist was available, but the patient was not enough to go to the radiologist. So you sent the patient to the OR, direct to the OR. In this case, we like to do non-operative treatment with interventional radiology, but for this patient, you discuss the patient was not stable enough for this option. Go ahead, my judge. In the
Dr.
post-operative,
Fraga, can I ask you a question?
okay.
How did you conduct the surgical part of this case? Did you do a midline incision and then open the retroperitoneum, or did you do a Cattell-Brasch maneuver to expose the right kidney?
Dr. Mayra, she operates the patients.
Oh.
We did a median open incision, and then we did the Cattell to assess the retroperitoneum, and then we found the hematoma, and then after we could find the duodenum and Cauchy movement, and then we find the aorta after Cattell.
There was a large hematoma on the right, zone 2 on the right, and in zone 1, the same. They did the Cattell maneuver and Cauchy maneuver. And the first option was to identify the vessels, the cava vein and the aorta, to have the control of the artery and the vein, renal artery and renal vein. And was possible to have the control, but the injury, the kidney was shattered, so it's very difficult to try to preserve to do a partial nephrectomy in this situation. So the option was to do a total nephrectomy. And the patient received 2 units of blood when the patient was going to the OR, and in the OR, no more blood was necessary because they controlled the bleeding, and I think it was good for the patient. Unfortunately, he lost the kidney, but the other kidney worked well, so I think it's not a problem for the patients. Okay, Dr. Kassim, do you want to comment? It's about to have the vessels control.
Exactly what I would have done, exactly the same thing. It was beautifully done. Thank you.
Yes, we always talk about have the control of the vessels before exploring the hematoma, but sometimes it's difficult. You try to go to the vessels, start to bleed. You need to perform a quickly nephrectomy. But in this case, it was possible to have the control, but it's not very frequent to do this.
It is a good lesson to learn from you for those of us who are not doing this every day. Thank you.
Thank you, Dr. Kassim.
Thank you.
Dr. Fraga, would you like me to go through the panel for the comments?
Yes, just to tell about the follow-up of the patients.
After surgery, we left an abdominal drain, so there was a low output and serum blood flow, and we discharged 6 days after surgery, but we maintained the patient in the hospital to see the liver injury. So we decided to maintain a little more time, but he was eating and no more bleeding by the drain. So we follow, and now he's following up with nephrologist, but no kidney injury by the exams. So that's it.
Thank you, Dr. Negrao. Thank you very much. So we'll go to final comments. Dr. Antrak, any comments?
Yes. So interesting case, and during the laparotomy, a couple of points. First of all, the kidney looks like in the photograph, the upper pole was at the bottom of the picture, and about half of the kidney was intact. But I can certainly sympathize with your feeling at the time that you had to do a total nephrectomy, and that was certainly appropriate. In this case. The other thing I would have done in the exploration after returning the viscera back to the right colon back in place would be to explore the lesser sac and just be sure that there was no injury to the pancreas, given the hematoma. So I would have added that. You probably at some point did check the pancreas and found that it was okay, and in follow up, nothing arose. There was no fluid collection in the lesser sac, so everything turned out fine. But I would have included that in the exploration.
Thank you, Dr. Antrak. Dr. Byers, your comments, please.
Yeah, I think, when you're doing a life-saving maneuver of someone like this with a renal injury, you can pretty much predict most of the time that you're going to end up with a nephrectomy. That being said, I agree that if you could have gotten some proximal control with a more stable situation, this patient looked like they would have been a candidate for a partial nephrectomy. I also agree about exploring the retroperitoneum. I don't know, I wanted to ask the group because, I've been doing a lot of work with motorcycle crash victims, and we have an ongoing study of them. In your area or your country, if they find a motorcycle crash patient on the side of the road without vitals, do they ever get resuscitated, or do they just usually don't get resuscitated?
Dr. Fraga, I think Dr. Fraga is. Dr. Fraga, we cannot hear you if you're talking. Okay.
Can you hear me?
Yes, we can hear you now. Yeah.
Okay. In the city of Campinas, pre-hospital, you have the SAMU, this national system with pre-hospital. We have the physician work at the pre-hospital with the regulation, and they go to the scene when it's necessary. Some motorcycle crash, usually they send the advanced support with the ambulance because of the high energy of the trauma, usually is high energy. And they start to treat the patient at the scene to resuscitate the patient. They put the cervical collar, immobilization, if necessary, if the patient is on coma. Sometimes they protect the airway with a definitive airway in the pre-hospital, and have a venous access to start to give fluid for the patient, and remove the patient for the hospital. Sometimes it's difficult because you don't have an organized trauma system in the country. Sometimes a critical patient go to a small unit. This is a problem because you need to transfer the patient later. At the road, you have a private system. They have ambulance, is a private team with the physician in the regulation. And sometimes the physician go to the scene when you have a critical case, like no, not this case, but if the patient is on coma, on shock, and you try to remove the patient as soon as possible to a trauma center. A hospital usually is a university hospital that take care of trauma patients in Brazil.
Yeah, well, we looked at autopsy studies, and in Dade County, we don't do, they do not resuscitate trauma patients that are found dead on the scene, you know, which is different than even an unwitnessed arrest in an elderly person, right? So we found, interestingly, that 30% of the fatalities actually had survivable injuries, with most of them just dying from airway obstruction. So I was just wondering, because here, I mean, we don't really have a big problem because we have a pretty sophisticated trauma system, but we do have Florida, we have the highest motorcycle fatality rate in the country, which is a big problem. We have at least 500 to 600 fatalities a year from motorcycles in Florida alone. So it's a huge problem. So I'm just wondering what your policy was, because if you look, different places have different policies with regard to traumatic arrest, resuscitation.
Thank you, Dr.
Perfect.
Weiss. Dr. Hochman, you have any comments? Or any?
No, I kind of like this to come out. There is no way to save this kidney because the injury involves the hilum. I know that there is a tendency now at equating the penetrating and the blunt injuries in trauma. Having said that and dealing with both, the penetrating injuries is easier sometimes to save the kidney. In the blunt injury, it's usually too messy by the time, usually you treat non-operatively and you need to operate, the kidney have to be removed. So that's the reason we try to avoid the surgery. I have seen bleeding from penetrating injury, usually stab wounds, that we go in and we manage to save the kidney, but those are the exception. Two comments about the approach. I completely agree, Dr. Fraga, the way you approach, I don't know if it was you or Dr. Negrao, or the way you approach this. In order to get a good exposure, if you can, you do the Cattell maneuver, and after that you do a complete Cochran maneuver. The classical teaching of the Cochran maneuver is that you mobilize the duodenum and the pancreas until you can visualize the aorta. For me, in trauma, you mobilize until you see the left side of the aorta exactly the way that you're showing in that picture, because that's the only way to get really good exposure for this and get vascular control. Sometimes you don't have the luxury to get vascular control. You just grab the kidney and clamp at the hilum. In this case, you needed to do something else because there was an injury in the inferior vena cava. A quick trick to get control of the inferior vena cava when you have this type of bleeding and the patient doesn't have an IVC filter, because that's a problem, is just to press with 2 fingers over the IVC in the area that we have the hole. So instead of wasting time dissecting the IVC completely, is pressing the IVC from anterior to posterior with fingers, keeping the hole in the middle. Use that as a term to quickly repair the inferior vena cava, which appears to be more or less what you did in this case. And I don't know how the things are done in different countries. I would not pretend to tell anyone how to do things in different countries. I would say how the things we do here. This is an injury that is managed exclusively by the trauma surgeons. It's extremely rare that we will involve urology. And I think the main reason for that is the way of thinking. We think globally. We have a patient who is very unstable. We need to be very expeditious dealing with this. If you bring someone who doesn't do emergencies, many times they will spend an inordinate amount of time trying to save something that is unsalvageable, and you end up with saving the kidney in a dead patient because it took too long to get fixed. So Dr. Fraga, you did, by my standards, you and your team did everything perfectly. I have nothing that I can add except a few comments how we do the things here. Congratulations, great case.
Thank you, Dr. Rahman. Dr. Kasim, any final comments?
I would echo everything Dr. Hoffman has just said. One of the tricks that I have learned, Dr. Hoffman, instead of using your finger onto the IVC, you can use a sponge stick as well, because it gets the hand out of the wound, and then the sponge stick technique, you have more visibility with the sponge stick technique rather than putting your whole hand into the wound as well. And that trick was from Dr. Dimitriatis from UCS, USC, sorry. I think the way Dr. Fraga, your resident or your chief, your associate conducted the operation is perfect. That's exactly what I was taught, and a lot of the urologists don't do that. They open the midline peritoneum and try to get control that way, and then they get into massive bleeding, and then they call the vascular surgeon immediately, and they get into a panic. And that's happened to me once. My urology friend called me in the middle of the night to get control of the patient as well. And again, Dr. Hoffman mentioned that in his summary. Very well done, beautiful case, a lot of lessons to be learned here, especially for residents or doctors who don't do this sort of surgery very often. Thank you so much for teaching us today.
Thank you, Dr. Kasim. We have a question from Dr. Mayra Lamote. Dr. Lamote. Okay.
Yes, thank you very much for the case presentation. I have a question. So if the patient would have had kidney trauma injury grade 1, 2, or 3, we wouldn't have done the nephrectomy, right?
And Dr. Antrak or anyone can.
Sorry, may you repeat the question, please? I didn't understand.
Yes, if the patient would have had a kidney trauma injury grade 1, 2, or 3, the patient will have or undergo the nephrectomy, right? Because the operation is just for grades 4 and 5, isn't it?
Normally, if it's blunt trauma, we would try not to operate in minor injuries. This case, the indication for surgery is the active extravasation, which is bleeding into the collecting system. So it's not likely to tamponade. It will continue to bleed. The only indication to do interventional radiology is to embolize the artery and decrease the bleeding when you go into the OR, but usually takes too much time. If it's a grade 1, 2, or 3 and it's not actively bleeding, we will not explore. Unless it's a penetrating injury and we are exploring from something else, and in that case, I think it's reasonable to try to save the kidney. I hope, did that answer the question?
Yes, perfect. Thank you very much.
Thank you, Dr. Lamote. Where are you calling from, Dr. Lamote?
At present, I'm in Atlanta, but I and my sister are from Mexico City.
Okay, thank you. Thank you for joining. Okay, do we have any other question or comment? Yeah, Dr. Untrak, would you like to make a comment?
Yes, so I'm just very curious with all these motorcycle cases that get presented. Dr. Byers mentioned that that she's doing an ongoing study of these patients. Dr. Byers, do you know what fraction of these patients, when they recover from their injuries, go back to riding motorcycles?
Dr. Byers, we cannot hear you.
AWOL, Dr. Byers is AWOL.
Oh, too bad.
Yeah, she will be probably, she's doing something else. I think we have another question from, when she's back, when I see her connected, Dr. Antrak, we can go back to her. We have a question, Dr. Viñoles.
Yes, congratulations for the case. Is possible partial nephrectomy in trauma? This is the question. See if it's possible. Partial nephrectomy in trauma.
Not sure, Dr. Fraga, would you like to respond, or Dr. Fraga?
Yes, it's possible, partial nephrectomy in trauma. In stable patients, if you, during the laparotomy, if the patient is stable, you have control the bleeding. It's very important to control the bleeding first, and you can do a partial nephrectomy. Sometimes you do this, but if the patient is unstable, or if you have a critical injury, like in this case, it should be very difficult to try to do a partial nephrectomy, because it was in exactly in the middle of the kidney, the injury, and it was bleeding. So the option was for total nephrectomy, is safer for the patient, but it's possible.
Thank you very much.
Perfect, thank you. Any other comments? No, okay, so let me share briefly the code. Dr. Martos, would you like to make a final comment? Yes.
Yes, so just to let you guys know, management of renal injuries are very nice and very, very difficult to manage sometimes. So I had some cases before that when a blunt trauma with a perinephritic hematoma, I did not operative management, but remained the patient is excruciating pain. And then when we took the patient to the operating room, the kidney was not working well. We found like a patient kidney. We found like the ureter doesn't expand a lot, and I had a compartment syndrome of the kidney. The kidney was completely pale. As soon as you open the ureter, evacuated the hematoma, the kidney, the color came back. So you need to remember, even if you do not operative management, sometimes you need to monitor the kidney, because sometimes the hematoma, the same compression is good to stop the bleeding. Sometimes you're gonna make like a compartment on the kidney. So compartments don't happen only in the abdomen, they don't happen only on the legs, can happen in the kidney as well. And I had a couple of cases when I had acute injury to the renal artery. I remember 2 cases where we did auto transplantation of the kidney. So called you can reimplant the kidney at the same patient. And here I had the privilege to have the kidney transplant people in house, but that's another option we can have sometimes to auto implant the kidney in trauma. Just remember, this is another situation that can face in trauma, especially in gunshot wounds. Regarding the access of penetrating injuries, sometimes it's hard, and the most important about what to do, if you can do partial nephrectomy or not, is the grade and where the injury is. Is a polar injury, like a peripheral injury, so usually can do partial nephrectomy. But everything will depend on how stable is the patient. Is the patient very coagulopathic, has many other injuries, so we most likely not going to be able to preserve the kidney. If the kidney is the only injury, so you most likely have some more time to deal with that. But if your patient, again, everything depends how critical is the patient. If you can do some damage control, or you just need to quickly stop the bleeding and send the patient to ICU with other injuries. So it's gonna affect also the management of your kidney injury, depending on how critical the patient is. Just some comments again. I got another good case from Dr. Fraga.
Thank you, Dr. Martos. Thank you.